Okay. Yeah, I think we'll make a start. Welcome everyone to this week's teaching. This course of teaching is primarily aimed at pediatric trainees, postgraduate pediatric trainees from Papua New Guinea and from the Solomon Islands and from Vanuatu, and usually we have somewhere between 10 and 15 people on this teaching, and we go through a curriculum that is what the postgraduate pediatric trainees in Papua New Guinea at the School of Medicine in Papua New Guinea need to go through. This week we have some friends from Yogyakarta in Indonesia, so very welcome to you. This has been organised by my colleague Dr. Ita Kartika, so welcome to you all as well. Some of you might have seen the last 4 weeks of teaching, or some of the last 4 weeks of teaching, and you're welcome to look at that online. There's a few more people entering now, so I'll just admit them as we go. Today we're going to talk about pneumonia and bronchiolitis. Now I know that most of you know what bronchiolitis and pneumonia is, but I want to talk about both the simple pneumonia and bronchiolitis, but also complicated types of pneumonia, particularly complicated pneumonia, so that we can recognise the most complicated forms. So I'm going to talk about the basic things first. So I'm going to talk about the causes, about clinical signs, predictors of a bad outcome. And I think we are not very good actually at doing risk assessment for children who've got pneumonia. And I think this is really important that we do risk assessment to identify the children that might have more complicated forms of pneumonia. I'll talk about treatment, and I am going to talk about complications of pneumonia, especially empyema, effusion, and lung abscess. So I'll be talking about those things. First of all, I want to talk about etiology, because we know a lot more about the etiology of pneumonia in the last 10 years. And I think previously in some parts of the world it was thought that pneumonia was just due to a couple of bacteria, and still those bacteria, Streptococcus pneumoniae and Haemophilus influenzae type B and non-typable Haemophilus, are the most important causes. Certainly in Papua New Guinea, those two bacteria were the dominant causes of pneumonia back in the 1980s and 1990s. But since then, the epidemiology of pneumonia has been better understood, and there's been some changes also to the epidemiology of pneumonia because of vaccines against Streptococcus pneumonia and Haemophilus influenzae. And we now, of course, have the Hib vaccine and the pneumococcal vaccine. And what that means is that there is proportionately a bit more of other forms of pneumonia. And I'll just go through some of the other pathogens. So we certainly see viruses causing a lot of the cases of pneumonia these days. So 40 to 50% of all cases of pneumonia are probably primarily due to viruses, and about I'll just admit some people, and about 30% of those, in almost all studies in all countries, about 30 to 35% of all cases of pneumonia are due to respiratory syncytial virus, RSV. And then there's some other viruses, parainfluenza, adenovirus, and seasonally influenza A and B. And of course, now there's SARS-CoV-2, which is causing quite a bit of pneumonia in children throughout Asia and the Pacific. As well as Streptococcus pneumonia and Haemophilus influenzae, there are some other pathogens that cause pneumonia as well, not commonly, but mostly in children who have comorbidities or other confounding factors, such as Staph aureus causes pneumonia. And the reason to identify Staph aureus is that the antibiotics required are different, and also because it's more likely to cause complicated pneumonia with empyema and effusion. And then group A Streptococcus, group B Streptococcus, and gram-negative bacilli also cause pneumonia. So we need to be alert for those pathogens. And then about 5 to 10% of all causes of even acute pneumonia in all the studies that have been done in Africa, in Asia, still about 5 to 10% of cases of acute pneumonia are due to mycobacterium tuberculosis. So we really need to be able to identify what simple pneumonia just caused by pneumococcus that will most likely respond to penicillin or amoxicillin from that pneumonia that's due to Staph aureus, or that pneumonia that's due to mycobacterium tuberculosis, or the pneumonia that's due to some atypical pathogen. Now, these pathogens, at least in Papua New Guinea, are not very common. So about 5% of all cases of pneumonia are probably due to atypical pathogens, mostly in older children, so Mycoplasma pneumoniae and chlamydia in young infants. Chlamydia is a important cause of pneumonia in children under the age of 3 months. And in children who've got HIV, then of course Pneumocystis jirovecii is an important cause of pneumonia. So they're the most common causes of pneumonia. If you look at the total 100% of cases, then this is roughly the breakup of the proportion that is due to each etiology. Now that varies from location to location, but in Papua New Guinea and the Solomon Islands, this is what we primarily see. The problem is that there's often not just one pathogen, and mostly there is a virus that causes an upper respiratory tract infection that leads to drip aspiration of saliva. Excuse me while I just admit a couple of people. Welcome, Leilani from Palatau. There's usually a virus causing an upper respiratory infection that leads to a drip aspiration of nasopharyngeal bacteria into the lungs. And that's why pneumonia is much less likely to be bacteremic in nature. It's usually due to aspiration pneumonia, drip aspiration from a viral infection. I'll just admit something. For those who are just joined, please mute your device if we're while we're talking. Most pneumonia is this. It starts with a viral infection like a rhinovirus or para-influenza or influenza or RSV, and then you get secondary bacterial infection from the bacteria that colonize the nasopharynx, and it drips down into the lungs because the nasal mucosa, the airway mucosa is damaged in some way. And that's the most common cause of pneumonia. There's also the type of pneumonia that gives you bacteremia, where you get an invasive bacterial disease that circulates in the bloodstream and then gets to the lungs. But most of it is aspiration pneumonia, and often there's more than one pathogen. There are some children that seem to get recurrent pneumonia, and most often that's recurrent viruses. Multiple viral infections can occur even in the one season. So a child can get RSV 2 or 3 times within the 1 year. Sometimes in children with recurrent pneumonia who have what we call chronic wet cough, children can have bacterial bronchitis. That is, that they're colonized within their lung with Haemophilus, and that typically can flare up when they get a virus. Or sometimes if they've got more underlying chronic lung disease like bronchiectasis, then Klebsiella or Pseudomonas or Staphylococcus, if they've got some chronic debilitating or immune compromised lung disease. And then some children with so-called recurrent pneumonia actually have tuberculosis, and they present, they get some antibiotics, they seem to get better, and then they get worse again. So the etiology of pneumonia is complex, and that's why we need to be able to take a good history and really understand the progression of the child's infection. These are the standard treatments that we give for children with pneumonia. So for children with, follows the World Health Organization's guidelines and also the Papua New Guinea guidelines. It would be similar in Indonesia as well. So severe pneumonia I'll just admit a couple of people. Severe pneumonia, has emergency signs or danger signs, or hypoxaemia, saturation is less than 90%, or cyanosis. And the standard treatment is to, I'll just let some people in. Some people are coming late. The standard treatment is to give oxygen, benzyl penicillin and gentamicin, or amoxicillin and gentamicin. If the cough persists for longer than 14 days, then assess for tuberculosis. That's standard treatment. But we need to be able to identify when children with pneumonia might have something else, and that's the challenge. Moderate pneumonia is often bronchiolitis, viral bronchiolitis. So these children have chest indrawing, but no danger signs, and they're not very hypoxemic. And the standard treatment is to admit them, give them benzyl penicillin or amoxicillin, and again, if the cough persists for more than 14 days, then assess them for tuberculosis or some other cause. But again, we need to be able to identify when children, even with moderate pneumonia, might have something else. Okay, mild pneumonia, or what WHO calls just pneumonia, is fast breathing with no chest indrawing, no danger signs, and no hypoxemia. And those children can be discharged on oral amoxicillin. And then the simple cough, which is not pneumonia, it's just a upper respiratory tract, usually viral infection. Those children have a normal respiratory rate. They have just upper respiratory tract infection signs, no chest indrawing, and no danger signs. And the treatment is home treatment with symptomatic treatment only. Continue breastfeeding or encourage feeding, give paracetamol if the child's febrile. So that's the standard treatment as recommended by the World Health Organization and by the Papua New Guinea standard treatment guidelines. I would say that, could you please mute your device if you can? Thanks, sir. I would just say that the assessment of severity is sometimes difficult. Elvira, could you Elvira, please mute your microphone, please. Okay. The assessment of hypoxemia is often very difficult, and as you know, these days the best way to assess hypoxemia is with a pulse oximeter and oxygen saturations. But before we had that, there are many children who I think had quite severe hypoxemia. This small baby was seen on a ward round and was passed over on a ward round as having not severe hypoxemia, but you can see the saturation is 66. And when you look at the baby, well, you can see that he looks a bit cyanosed and he's got marked chest indrawing. So you need to look carefully for the signs of hypoxemia, and it's especially difficult if you're in a dark room, I think, in a dark ward. So you need to have a good look with a good light to see whether there's cyanosis of the lips or the gums, and see whether there's chest indrawing. I'll just show you this video of a small baby who presented with cough and respiratory distress. I want you to notice just how much this child has respiratory distress. You can see his chest indrawing, his hyperinflation, his nasal flaring. He's still conscious and he's still alert, but he certainly has a degree of severity of, I'll just admit some people here now. He certainly has severe chest indrawing. Now, this boy could have, whenever you see a child like this, you have to think to yourself, is it his lungs, or is it his heart, or is it both? And in this case, the child's x-ray looked like this. And so it's very hard to distinguish, isn't it? This child had severe consolidation of both lungs with severe pneumonia, and also had heart failure related to his severe pneumonia. And he also had anemia. So his hemoglobin was only 6. So when this child was given oxygen and antibiotics and a blood transfusion to give him a higher hemoglobin and some diuretics, he improved. But if without identifying all of those complications, the child would not have improved with antibiotics alone. I want you to have a look at this baby and see how he differs. It's a little different. I'll just show you. I hope what you can notice from that video is the baby doesn't look very unwell, he's still alert, but he has severe respiratory distress and he has marked hyperinflation. And I hope you notice that the noise he was making, and sometimes we think of respiratory noises as being stridor or wheeze, and I hope you noticed the phase of respiration that the child made the noise. The phase of respiration wasn't on inspiration, it was on expiration. So this baby had a prolonged expiratory phase, and that's typical of a child who's got very severe bronchiolitis, right? Less common in a child who's got pneumonia. So hyperinflation with a prolonged expiratory phase and a prolonged expiratory wheeze that was audible even without a stethoscope. This is the X-ray of that same baby, and you can see that there's no dense consolidation of this baby's lung, but alternatively there's hyperinflation, where you can see an elongated mediastinum with flattened hemidiaphragm, especially the left, and hyperinflation of the lungs, and a bit of reticular interstitial opacities, but not too much. There's not any dense lobar consolidation or any miliary pattern or any effusion or anything like that. There's just hyperinflation. And this is an X-ray of typical of a baby who's got bronchiolitis, as that previous baby had. So I guess part of what I wanted to convey today is the complexity of making a distinction between bacterial pneumonia and viral bronchiolitis, and the concept that sometimes there are children who have both going at the one time, some bacterial component and a viral component. Bronchiolitis is, the pure bronchiolitis, of course, is all viral. It's self-limiting, but it can still be severe, as that baby had, I showed you before, quite severe respiratory distress and hypoxaemia. It can be severe. Usually occurs, of course, in infants who usually look relatively well looking. They have fast breathing, but they look generally happy. That baby I showed you didn't, because he had severe respiratory distress. They have chest hyperinflation. They have a prolonged expiratory phase. They have wheezes and crackles. That's very important, because sometimes we just think that bronchiolitis, you just have wheeze, but often these babies have crackles, inspiratory crackles in their lungs, the sounds of wet secretions moving in their airways. Sometimes in neonates and young infants, they have apnea. They typically are worse day 1 to 3, and then they improve on day 4 to 7, but it can be associated with a more prolonged illness, and that can go for several weeks. And it's not uncommon with babies with just acute viral bronchiolitis to still be coughing and have wheeze at 10 to 14 days. I think if it goes beyond 2 weeks, then there's probably something else going on, but sometimes even a bit of wheeze can persist for up to 3 weeks. With bronchiolitis, it's usually not associated with a persistent high fever. While some babies with bronchiolitis present with a fever, usually it's not a persistently high fever. And I think a persistent high fever that goes for several days should trigger us to think there could be something else going on in babies who've got bronchiolitis. The usual care for children with pneumonia is well described in the Hospital Care for Children book. And the basic treatments are these: standard treatment with antibiotics, oxygen therapy, monitoring of the patient, supportive care with nutrition and fluids. But as I said, I think we need to have a sort of a better approach to risk assessment to be able to identify the child that's at higher risk of dying. And we can do that by looking for emergency signs, hypoxaemia, malnutrition, anemia, HIV. Newborn babies and young infants have a higher risk. Children with a chronic comorbidity. And sometimes we can use laboratory tests like looking at the blood lactate, which I'll explain in a little while. So I want us to be better at risk assessment for children with pneumonia. I think we're all good at standard treatment, but all children who are admitted should have some assessment of the risk that they have an alternative diagnosis or very severe pneumonia. And part of improving hospital care for children with pneumonia is a quality improvement program and auditing of outcomes. this is old data now, but this is done about 15, 20 years ago. And what it shows is that children who come into hospital with severe pneumonia, who have hypoxaemia, have a much greater risk of death if their oxygen saturation is lower. So this is the oxygen saturation on the x-axis and the probability of death on the y-axis. And I think it tells us many things. This is 1,000 children with pneumonia, with severe pneumonia. And all these children came in with an oxygen saturation that was less than 85. They had very severe pneumonia. But what you can see is that their risk of death is about 5% if they have an oxygen saturation of 85%. But if it's 50%, if their oxygen saturation is 50%, then their risk of death is close to 10%. So it's still not very high if you give them enough oxygen. And the point of this graph is that even if the oxygen saturation is very low, if you give enough oxygen, you give standard treatment, you give antibiotics, then most children will get better. All right. And so this graph shows us how long it takes these children to get better. And it shows that some children with pneumonia, this is the days to resolution of hypoxaemia, and this is the proportion of children. So most children, their hypoxaemia resolves over a few days. Most children, it's better over a few days. But even after 10 days, about 15% of all children will still be hypoxemic and they'll still need oxygen. Even at 20 days, about 10% of children, 5 to 10%, will still be hypoxemic. And at 30 days, about 3% of children will still be hypoxemic. And so what we have to understand is that hypoxemia can be a bit prolonged in some children with severe pneumonia in some situations. And we looked at the average duration of hypoxemia in children in the Highlands, and that was somewhere between 4 and 8 days. And the average duration of children in coastal areas is somewhere between 3 and 4 days, or 1 to 2 days with moderate pneumonia. So it can be long or it can be short, and we need to make that assessment. I'll just show you again to underline how, oops, oh, that's not working. Oh no, sorry. This video looks like it's gone wrong. I'll just try this one. This baby had saturations, you can see, of 50% at the time he presented. And this is just a few, oh, this has gone wrong again. Sorry, this is only 1 minute later. And the oxygen saturation you can see there is 98%. And that's only 1 minute later with just some oxygen. And so it just tells you how effective giving oxygen is. Sometimes oxygen needs to be provided to a lot of babies when there's outbreaks of RSV or other infections. And this is how oxygen therapy is set up in district hospitals in Papua New Guinea. Oxygen therapy is extremely beneficial when you're giving it to children, especially in rural and remote areas. I won't go through this data, but it shows that if you give oxygen therapy effectively to children in remote health facilities with pneumonia, you can almost halve the mortality from pneumonia. I won't go through the details, but the outcome was 50% better when oxygen therapy was given through to rural health facilities. All children in hospital wards who have pneumonia need to have monitoring charts that reflect their responses. And so you can see here this monitoring chart this type of monitoring chart I think is highly recommended. It's a color-coded monitoring chart that has red areas for where the child's in danger, yellow areas where the child's not normal but not in great danger, and white areas where the child's within the normal range or close to normal range. And this monitoring chart's got the temperature, the respiratory rate, the oxygen saturation, the degree of respiratory distress as assessed by the doctor or nurse looking after the child, the heart rate, the capillary refill, the blood pressure, the AVPU score, the alert, verbal, pain or unresponsive score, which we use, the blood sugar, and any volume of feeds that are given, and any other therapies that are given. So having a monitoring chart like this can really help look after such children. And you can see when their vital signs are stabilizing and getting out of the red zone and into the white, or you can, conversely, you can see if they're deteriorating and the vital signs are getting into the red zone. And to do this properly, you need to have charts with some clear method of response. And many hospitals around the world now have MET systems where if a child enters the red zone, then there needs to be a call made and a doctor will come to the bedside, or a team of people will come to the bedside to try to change the physiology and improve the situation by making some intervention. This has transformed the way hospitals function in many countries, having monitoring and response charts and having MET systems or methods of response. And I think all hospitals can have that sort of thing. I talked before about risk assessment of children with pneumonia, and I think it's really important. We need to, when children come into the ward, we need to be able to decide not just do they have severe pneumonia or moderate pneumonia, but do they have any risk factors that might indicate an alternative diagnosis or an additional diagnosis, or they might be at high risk of deteriorating or dying. And these are the factors we should look for. So are they hypoxemic or not? Do they have emergency signs or not? Are they severely malnourished or not? Do they have anemia or severe pallor, conjunctival pallor? Are they newborns or young infants under 3 months of age? Do they have chronic comorbidity like cerebral palsy or HIV? Do they have a lactate that's high, or do they have evidence of metabolic acidosis so that they might have sepsis? Now, not all hospitals can measure lactate, but it's a very good marker. Like using pulse oximetry, the measurement of lactate or metabolic acidosis can be a good adjunct to risk assessment. And then also X-ray changes. Now, we don't X-ray every patient with pneumonia, but only children who've got severe pneumonia. But you need to know which signs on the X-ray should cause us to think that the child is at high risk. Certainly a miliary pattern would cause us to think maybe they're one of that 5 to 10% of children that have tuberculosis. If they've got an effusion, we should think, do they have an empyema, or do they have staph infection? Or if they've got a lung abscess, do they have a staph infection or some other pathogen causing this? Is it not just simple pneumonia? And I think that's where we need to be a bit better at identifying children at high risk of deterioration with pneumonia so that we can put in place measures to reduce that risk of deterioration. I'll just talk briefly about how lactate, that measurement of a metabolic acidosis, can be very helpful. I won't say too much about this because not all hospitals can measure lactate, but there are now like lactate measurers like glucometers. And it was a very useful measure in these children in Malawi mostly with bacterial pneumonia. And the best measures of risk of a bad outcome, risk of death, were hypoxaemia, hyperlactatemia, and then age under 12 months. And I just want to show you this graph that shows this is the oxygen saturation measured by pulse oximetry, and this is the probability of death. And this is if the lactate was less than 2, and this is if the lactate was greater than 2. And you can see that when you add lactate to hypoxemia, you get much better prediction of a poor outcome. And so the combination of those two measures, pulse oximetry and the measurement of blood lactate, is very helpful. But I think if we don't have lactate, there's a lot of other clinical features we can look at that are just as good, but lactate can add to that. I won't say any more about that, but I think as we get a bit better at risk assessment, these sorts of things become quite important. I wanted to just briefly discuss a case because I think it illustrates how we in terms of risk assessment, we need to be identifying children that don't just have simple pneumonia, right? This was a 3-year-old boy. He'd been previously well. He'd had 6 days of runny nose, coryza, and cough, and a high fever for 6 days. He was seen by a general practitioner who thought that he just had a virus. But then for the last day, he'd had tachypnea, more fast breathing. His mother, this boy was originally from overseas, and his mother had been treated for tuberculosis as a 14-year-old, but not recently. She'd been quite well. But this was his chest x-ray. So you might think, based on the story, 3-year-old boy, previously well, 6 days of coryza, cough, and high fever, just like the GP, general practitioner, thought it may well be a virus. When you look at the x-ray, it's clearly not just a virus. Excuse me. It's clearly not just a virus. And you can see this is not just ordinary pneumonia. This is a complicated pneumonia clearly with an effusion and a whiteout, almost a whiteout of the right chest. So on examination, this boy had a high fever, temperature of 39.5, a fast heart rate, a blood pressure that's a bit on the low side, 85 on 35, that's a bit low. He was able to communicate, but he was very lethargic and not very responsive. His initial treatment was oxygen and ceftriaxone and Fluclox, but I hope you all know that would be completely inadequate. That's necessary, but not sufficient when you've got a chest x-ray that looks like that. And so he went on to have a pleural drain put in. You can see this is what's called a pigtail catheter. It's a very easy drain to put in, but a normal pleural drain or an underwater seal drain or an intercostal catheter, any sort of drain is useful. And we got out 160 mils of thick serous fluid, and it had a lot of white cells with a lot of neutrophils. And he had gram-positive cocci and gram stain, so he just had pneumococcal pneumonia, gram-positive cocci on gram stain of his pleural fluid, and he was negative for TB. But in the absence of draining his chest, he wouldn't have got better. So he got put on benzoyl penicillin and flucloxacillin to cover staph in case he had staph pneumonia. And this was his ultrasound. Now, we're just starting to do, I think, chest ultrasound to identify pleural effusions, but I wanted to show you his ultrasound because it illustrates how ultrasound can progress over time. So this is the chest ultrasound. You can see this is the lung, and this is his pleural effusion. You can see the pleural effusion to start with before the drain was put in. You can see it there again. But what you can see in the middle, this is inside his lung. This is his lung here. You can see inside his lung something that looks like a bit like a cavity. And this was day 1. And on day 3, another ultrasound showed the fluid still there and the cavity got a bit bigger. So this is a form of what we call necrotizing pneumonia or cavitating pneumonia, which is a bit more complicated than the standard pneumonia. And it's typically associated with empyema. And so it's very important to drain the empyema and find the bacteria causing the pneumonia and treat with the right antibiotics. And usually supportive care is enough. Sometimes these children need a bit more. This child's pleural effusion and small abscess in his lung, it's a relatively small abscess. Sometimes they get better with just antibiotic therapy. It's rare that such children with necrotizing pneumonia need the abscess drained because the abscess is actually within their lung. So it's hard to drain such an abscess. But we need to be able to identify children that have necrotizing pneumonia and lung abscesses because they need a more prolonged course of antibiotics and they need good drainage of their empyema. Necrotizing pneumonia probably occurs in somewhere between 6 and 9% of hospitalized children. So children who've got severe pneumonia, most of them don't have necrotizing pneumonia, but usually they have progressive pneumonia despite appropriate therapy. We give the right antibiotics, but their pneumonia doesn't get better. Usually they're disproportionately sick. They're sicker than what you'd expect. And they have a persistent fever or persistent respiratory distress despite giving antibiotics, or they have radiographic signs that are a bit worse than normal. They have an empyema, or they've got a whiteout of one lung, or they've got progressive pneumonia on their chest x-ray. Now, sometimes we look at these patients and we say, oh, they've probably got TB, but sometimes they just have complicated pneumonia. And it's important that we identify these children, give them the right antibiotics, broad spectrum antibiotics that will cover Staphylococcus, but also pneumococcus. They're mostly due to pneumococcus and Staphylococcus. This is what their lung biopsy looks like. And we rarely do lung biopsies, but if you do, this is normal lung, which is well aerated. You can see the nice aerated alveoli. And this is what necrotizing pneumonia looks like. An inflammatory infiltrate. This was a child I had who had severe necrotizing pneumonia, and she had both hemorrhagic and necrotizing pneumonia. So inflammatory infiltrate with lots of red cells and pus cells in the filling up the alveoli and breakdown of the alveoli. So this sort of pneumonia is going to take many weeks to improve, and usually they require about 3 weeks of effective antibiotics. Usually they're due to Streptococcus pneumonia, the commonest cause of bacterial pneumonia, and sometimes they're due to Staph aureus, and sometimes they're due to these other pathogens. I won't go through all of these, but sometimes they're due to other pathogens. But remember that complicated pneumonia in children is typically complicated pneumonia in children is typically due to Streptococcus pneumonia and Staph aureus. This is a child who also had Staph aureus pneumonia, and she demonstrates what in a child who's got severe a viral infection followed by a staph infection. You can see how consolidated her right lung is compared with her left, and this was an X-ray at day 1, and then an X-ray at day 4. This is what happened, and it's not uncommon in children who've got staphylococcal pneumonia to develop a pneumothorax, and sometimes they do because they have a small pneumatocele that develops on day 3 or 4 or 5, and that can rupture. And so if a child's got staphylococcal pneumonia, be thinking that we need to keep monitoring them to see if they get a rupture of a tiny pneumatocele that might lead to a pneumothorax. So that sometimes happens. This child also had a complicated form of pneumonia, and you can see what I want you to see there is that within the lung you can see the consolidation, but there's a pocket of air, an air fluid level, and this is a lung abscess. So it is important we identify this, because otherwise we might think this is just consolidation of the lung, but in fact it's consolidation, but within it is a lung abscess. Now again, most of these don't require intervention, surgical drainage, but they do require more prolonged antibiotic therapy, and they require us to think what are the other pathogens that could be causing this, and typically they'll be Streptococcus pneumonia or Staph aureus. Sometimes they'll be tuberculosis, it'll be a cavity within the lung, so we just need to think about that. This was a child, some of you might remember, well, we saw this child just last week in the ward in Port Moresby General Hospital, and this boy also had consolidation of the middle and lower lobes, but he had an air fluid level as well. And this is also a lung abscess, and he didn't get better with standard antibiotic therapy. Why? Because he had a lung abscess. But with ceftriaxone and flucloxacillin, he got better from his pneumonia. I'll just show, it's useful to do a lateral X-ray sometimes, because what it shows, if I can just move this, what it shows is that most of the consolidation is in the middle lobe, but within the middle lobe there is an air fluid level, and that is the lung abscess within the middle lobe. So I've talked today about pneumonia, the simple and the complicated. I've talked about standard treatment and the recognition of children who have severe pneumonia, or children who are at high risk of having complicated pneumonia, or at high risk of having a deterioration from their pneumonia. And I think it's now time that we started being good at risk assessment. So I think that a comprehensive approach to pneumonia from both a prevention and a treatment perspective is really needed. And I've listed in this slide, this is my last slide, I've listed all the things that we can do to prevent pneumonia and all the things we can do to treat pneumonia. And to prevent pneumonia, we can give vaccines, we can promote vaccines, Haemophilus vaccine, pneumococcal vaccine, measles, BCG, they all help to prevent pneumonia, don't they? Pertussis vaccine, even the COVID vaccine, all help to prevent pneumonia. We can promote breastfeeding and better nutrition, because underlying many children who have recurrent pneumonia or complicated pneumonia is undernutrition, and typically occurs when children are weaning from breast milk and they don't get enough complementary feeds, they don't get on good nutrition and somewhere between 4 and 6 months, they start getting malnourished. We can promote the use of vitamin A and zinc. We can reduce indoor air pollution, that is smoke inhalation or smoke exposure by children. We can promote hand washing at homes and in hospitals. We can prevent HIV transmission, because many children with severe pneumonia will be children who are HIV exposed. We can be better at looking after neonates, so clean deliveries, preventing low birth weight where we can, providing early essential newborn care, and even preventing sexually transmitted infections will help to prevent pneumonia, because as I said, there is a fair number of children in early infancy, in the first few months of life, who have chlamydia pneumonia. They might not just have chlamydia, but they've got chlamydia with some other pathogen, right? So there's a lot of things we can do to prevent pneumonia, and then there's many things we can do to treat pneumonia better, and that includes early recognition and care seeking by parents, by mothers particularly. We can be good at outpatient treatment of mild and moderate pneumonia. We can have standardized antibiotic guidelines. We can provide oxygen therapy better and CPAP support, and we can have better monitoring in hospitals and emergency responses. And most important, I think, we can have better risk assessment. And that involves when children present, and each day we see them on the ward round, we can do a risk assessment that involves assessing for hypoxaemia and emergency signs and other comorbidities like malnutrition and HIV and anemia, cerebral palsy, other things that mean that children are going to have a more complicated outcome. And we can do better at the risk assessment based on x-rays and identify children who've got effusions or empyema or lung abscess or signs of tuberculosis like a miliary pattern on their chest x-ray. So we can do all those things, and that'll make us better at the management of pneumonia. All right. Now I'm going to stop there. I'm going to stop talking now. We've still got 5 minutes for questions. I wanted to cover the simple and the complex in pneumonia because it's fundamental to the management of pediatrics. So I'm happy to answer any questions that anybody might have.